Hi everyone, today is our first topic, which is GIT pathology, and today we are first going to speak about oral pathologies, which is including aphthous ulcers. It is also known as canker sores, and it is a common oral lesion that appears as painful shallow round to oval ulcers, and it is covered by yellowish exudate. Recurrent aphthous stomatitis is associated with celiac disease, inflammatory bowel disorders, which includes Crohn's disease and ulcerative colitis, SLE, systemic lupus erythematosus, Behçet syndrome, and HIV infection. Behçet syndrome, in this there is a recurrent aphthous ulcers plus genital ulcers plus uveitis, and this occurs due to immune complex vasculitis. It occurs due to immune complex vasculitis involving small vessels. And aphthous ulcers has a grayish base. It represents granulation tissue, and it is surrounded by erythema or redness. Then comes squamous cell carcinoma. It is the most common malignancy of the oral cavity. It usually affects the tongue and is associated with tobacco, alcohol, and human papillomavirus 16. HPV 16. We need to remember this. It presents as a non-healing ulcers with irregular margins and raised borders. It is a malignant condition, and it presents as irregular margins and raised borders. Okay, so the precursor lesions of squamous cell carcinoma are leukoplakia, which is white patch, and erythroplakia, which is a red patch. The patients with leukoplakia are worried about squamous cell dysplasia and there are some conditions which are not malignant. With these include the ones which are easily scraped. It is caused by oral candidiasis in immunocompromised patient. This means if it is scraped out, it means there is no dysplasia. Then comes hairy leukoplakia. It is seen on lateral tongue, and it occurs due to Epstein-Barr virus. That is, it represents hyperplasia and not dysplasia. So if these two conditions occurs, it means that it is not a dysplasia. The patient should not be worried. Then erythroplakia is a red patch. It indicates just a vascularized leukoplakia, and it is highly suggestive of dysplasia. Then comes silolithiasis. Silolithiasis is a stone formation in ducts of the major salivary glands. As we know, the major salivary glands are parotid gland, submandibular gland, and sublingual gland. Let's have a sneak peek into this a little bit. Yeah. There are three major salivary glands, and there are also many tiny salivary glands throughout the mouth, and all of these produces saliva. The first is submandibular gland. Its location is in the floor of mouth and just below the mandible. It secretes saliva into the Wharton's duct where it reaches the mouth. There is the sublingual gland. Its location is the floor of mouth and it is below the tongue. As we know, lingual is tongue, sublingual below the tongue. Then comes the largest gland, which is the parotid gland. Its location is behind the angle of the jaw, and it is below and in front of the ears. That's for the salivary glands, and it is associated with salivary stasis, that is dehydration in the trauma, and it occurs as a pre and periprandial pain and swelling in the affected gland. So we know preprandial pain is before eating, postprandial pain is after eating, and peri is like around the time of eating a meal, and it encompasses both the preprandial pain and the postprandial pain. Then comes silodenitis. So silolithiasis was stone formation. Silodenitis is inflammation of the salivary gland, and it can occur due to silolithiasis, due to obstruction from a stone, or it can be due to an infection such as Staph aureus or mumps virus, or it can also be due to an anaerobes. So for this, we give a treatment which includes double coverage. That is, we give naficillin for the Staph aureus infection, and we also give metronidazole or clindamycin for anaerobes. So we give double coverage treatment: naficillin and metronidazole or clindamycin. And it can also occur due to immune-mediated mechanism, Sjogren's syndrome. So now coming to know what is Sjogren's syndrome. Sjogren's syndrome is a condition, it is an autoimmune condition in which there is loss of tears in eyes and saliva in mouth. For this, there is a loss of saliva, so it can lead to infection. It can also lead to dental caries or cavities, because saliva contains proteins. Saliva does contain protein, as I have mentioned here, that saliva contains proteins that protect the teeth. Saliva contains protein that protects the teeth, and in Sjogren's disease there is an loss of tear and saliva in mouth. For this, we give them for Sjogren disease syndrome, we give them muscarinic agonist, because muscarinic agonist increases the saliva production, and it includes pilocarpine. And muscarinic antagonist is used for saliva regulation, and it can cause dry mouth, as it blocks saliva production. It includes atropine and scopolamine. These are the addition which we will learn in the pharma of the saliva regulation. So now coming to the salivary gland tumors. Salivary gland tumors are usually benign. If you hear about the tumors of the salivary gland, you will say it's usually benign. And benign is because it most commonly affects the parotid gland, and the tumor of the parotid gland is usually benign. If you hear that the tumor is in the submandibular, sublingual, or minor salivary glands, then it is most likely to be malignant. So first of them is pleomorphic adenoma. And before that, we need to know is that if it is a benign, then there will be painless mass, as it is not invading any nerves, and there will be just swelling. If you see a patient with facial paralysis or pain, then it suggests that there is a malignant involvement. Malignant is when the tumor is firmly attached to the underlying tissue, that is, it is not mobile. If it is mobile, then it means it is a benign tumor. Okay, so the first is pleomorphic adenoma. Adenoma suggests it is a benign, and pleomorphic adenoma is a benign mixed tumor. Now coming to know why it is mixed, because it is composed of two types of you can say tissue. The first one is chondromyxoid stroma and epithelium. So chondromyxoid stroma is a cartilage and epithelium is a gland. So it is made of two types. So it is known as mixed tumor, and it is the most common salivary gland tumor. We are mentioning it is the most common salivary gland tumor. So there will be different most common malignant tumor, but this is just among both benign and malignant. This is the most common salivary gland tumor. Also, we have already mentioned that benign is the most common tumor in salivary glands. So it is composed of two things, and it reoccurs if it is incompletely excised, or ruptured intraoperatively. So this has a high rate of recurrence, as it has irregular margin. So since it has irregular margin, there is a possibility that it is not completely excised or removed, and it can also be ruptured intraoperatively. So there is a chance of reoccurrence. Now next is it may undergo malignant transformation. It is not very common. It is a rare condition, but it may undergo malignant transformation. The next one comes is Warthin's tumor. Warthin tumor is also known as papillary cyst adenoma lymphomatosum. So adenoma, again, it is benign. Cyst, it is a cystic tumor. So papillary cyst adenoma lymphomatosum is a benign cystic tumor with a germinal center. Okay, and it may be bilateral or multifocal, and it is typically found in persons who smoke. So there is a trick. Warriors from Germany love smoking. Warthins, Germany, germinal center, and smoking, those person who smoke. So this is the second most common salivary gland tumor, and it usually occurs in parotid gland. And in this, the cyst is surrounded by lymphoid infiltrate. As we heard the name, cyst adenoma lymphomatosum. So the cyst is surrounded by dense lymphoid infiltrate, and lymph tissue can aggregate into the germinal centers. It is a benign cystic tumor with germinal centers. It has lymphoid infiltrates, and the lymph tissue can aggregate into the germinal center. So we need to note these points. Then the third one comes as mucoepidermoid carcinoma. It is the most common malignant tumor, and it is composed of mucinous and squamous components. Mucinous and squamous components, again, it is muco. So mucinous, epidermoid, so it is a squamous component, and it is a malignant tumor. Need to note this point. So since it is a malignant tumor, obviously it will be firm. It will be firm, and it will be attached to the underlying tissue. So and the key risk factor of mucoepidermoid carcinoma is if there is a prior radiation. It can occur in parotid gland. We earlier mentioned that it is benign and most commonly affects the parotid gland, but it's not always, and it can invade the facial nerve paralysis, as we studied before that in benign it does not invade the nerves, but in this condition it can invade the facial nerve. It can lead to paralysis, and it can also cause pain. So yeah, that's it for the salivary gland tumors. Then there's a clinical case that if a patient has a mass in parotid gland for 10 years, okay, and now he presents with a facial nerve problem. So initially it was a benign condition in parotid gland for 10 years, but now it is presenting with a facial nerve problem like paralysis or a pain. So this can suggest that the tumor has transformed into carcinoma. Like we also said before, said that pleomorphic adenoma may undergo malignant transformation. So in this condition the patient has undergone malignant transformation. Also we need to learn a little bit physiology of the saliva. So first we need to know that saliva has electrolytes. Salivary fluid is produced by acinar cells. Okay, so I'll draw it for you. Wait a minute. Okay, so salivary fluid is produced by acinar cells and it is modified by ductal cells. So this is let's assume this is an acinar cell, this is the ductal cell. So this is berry shaped acinar cell, berry acinar cell, and this is ductal cell. Ductal this duct contains ductal cells. Okay, and initial fluid produces the fluid. This produces the initial fluid, and it is similar, isotonic to the plasma. Okay, and this ductal cells, these modify the fluid. These modify the fluid. Okay, so and this opens into the mouth. Okay, so since it is isotonic to the plasma, so it contains sodium Na plus, Cl minus, HCO3 minus, okay, and K plus. Okay, and these ductal cells are impermeable to water. So these remove Na plus and Cl minus, and these secrete K plus and HCO3 minus. Okay, so this is there and this is removed. So now since HCO3 minus is a bicarbonate, it creates an alkaline environment, which helps to neutralize the buffer of the acid that can be introduced in the mouth when eating an acidic food or beverages. So this is essential for maintaining oral pH and prevents damage to teeth and oral tissue from acidic substances. So when Na plus and Cl minus is removed, this makes the saliva hypotonic. Saliva is hypotonic now. So now earlier in plasma Na plus Cl minus was there, and now it is removed in Na plus and Cl minus is removed from the saliva. So Na plus and Cl minus is more in plasma than in saliva. Alright, and opposite is of K plus and HCO3 minus. K plus HCO3 minus in plasma is less and more in saliva. Okay, now these composition can vary with the flow rate. If there is a higher flow, okay, the saliva is moving faster into the mouth. So what happens is there is a less time for the ductal modification. This duct gets less time for the modification. So now what happens is if there is a higher flow, the fluid becomes more like plasma. Because there is less time for ductal modification. So Na plus and Cl minus is not removed effectively. So and also you might be thinking that what about K plus and HCO3 minus? HCO3 minus, since there is a increase in flow rate, the metabolism in the glandular cells is increased, more CO2 in glandular cells, and hence more bicarbonate. You just need to remember that bicarbonate also goes up at high flow rates due to higher metabolism. Also coming about regulation of the saliva, saliva is regulated by the sympathetic and parasympathetic system. Now it is all, we need to remember that it is not regulated by the GIT hormones like gastrin or secretin. Sorry, there is an error, secretin or cholecystokinin. They have no effect on the salivary flow. Sympathetic has a comparatively lesser effect, and parasympathetic has a greater effect. It is a major system. It is also a major system that is activated in other features of the GIT like acid or hormone secretion. Parasympathetic system is activated with the food smell site, and in this the muscarinic receptors M1 and M3 are important. I already explained you the pharma of the saliva regulation, that muscarinic antagonist causes dry mouth and agonist increases the saliva production. So yeah, that's it. I forgot to mention about this slide. This is a slide of pleomorphic adenoma, in which it shows how it is a mixed tumor. So this part contains glandular cells, it is epithelial, and this part is the stromal part. These two are mixed, and this is a stromal part. It contains cartilage, and sometimes you may also see bone. So hence it is a mixed tumor. Now coming to the next condition, which is achalasia. A means without, achalasia means relaxation. In this we are talking about the achalasia of the esophagus. Doesn't mean that achalasia occurs only in esophagus. It can occur in other body parts also, where there is a failure of relaxation. So in this achalasia, it occurs from failure of lower esophageal sphincter to relax. The lower esophageal sphincter is not able to relax. Why? Due to degeneration of the inhibitory hormones. Now, inhibitory hormones usually force the LES to relax. Which inhibitory hormones? The nitric oxide and VIP, vasoactive intestinal peptide, which is situated in the myenteric or the Orbach plexus of the esophageal wall. So it is responsible for the myenteric plexus is responsible for the normal motility and relaxation of LES. In absence of this, in degeneration of these inhibitory hormones, there is a failure of LES to relax. Okay. Now, there are two types of achalasia, primary and the secondary. Primary achalasia is idiopathic. Secondary achalasia may occur from a chronic Chagas disease. Now, Chagas disease is what? It is caused by a trypanosomas cruzi infection. It is common in South America. It can also occur due to the secondary achalasia may also occur due to extraesophageal malignancies such as the Mars effect or paraneoplastic. There's a trick like Cha here and Eka here. So yeah. So acute Chagas disease is a febrile illness. But if it is chronically affected, it can lead to achalasia and dilation of the esophagus. Now, presence with a progressive dysphagia. What does progressive mean? That initially it is there is a dysphagia only to solids, but later on it can also lead to liquids. Also, like there's a difficulty drinking. This is opposed to obstruction, in which there is only obstruction dysphagia only to solids, and it is associated with increased risk of esophageal cancer. Now, patients also suffer from putrid or bad breath. Putrid is known as bad breath. It can occur due to the accumulation of the food in the esophagus, as the person is having dysphagia to both solid and liquid. And chronic accumulation of food can lead to inflammation, which is a risk factor of squamous cell carcinoma. Now, manometry findings include uncoordinated and absent peristalsis with increased LES resting pressure. Okay, so the LES resting pressure is increased, and the barium swallow shows that dilated esophagus. Why? Now see, since here the food is getting stored, so the esophagus gets dilated, and since there is failure of LES to relax, so there is in the distal part of the esophagus there is a stenosis. This represents like a bird beak, because LES is tight and close. So barium swallow reveals bird's beak, and treatment includes surgery, endoscopic procedures, and botulinum toxin injection to relax the muscles, because botulinum toxin is basically Botox. So Botox purpose is to relax the muscles. Esophageal manometry is helpful in dysphagia correction. It measures pressure change with contraction. It shows increased LES tone. Here the tone is increased. We need to remember the LES tone is increased in achalasia. There is another condition, scleroderma. In that also patient has dysphagia. In that LES tone is decreased. You need to remember the difference. Okay.